So I hope, as everyone knows by now, I'm Melissa Beck, the Executive Director of the Sozosei Foundation. I have the honor and privilege of being in conversation now with a group of leaders from South Carolina, and I want to acknowledge that Sheriff Leon Lott, who is part of our mighty panel, has not made it today due to airline incidents, traffic, beyond his control. And we miss him, but we will represent. All right, so let me give quick introductions. Starting all the way on my left is Dr. Kenneth Rogers, who's the State Director of the South Carolina Department of Mental Health. To his right is Allison Farrell, who's the Director of the Office of Emergency Services for the South Carolina Department of Mental Health. And to her right and my left is Major Maria Yturria, also, or of the Richland County Sheriff's Department, which is also where Sheriff Lott is from. We are going to begin with you, Dr. Rogers, and I'd like for you to sort of level set for our audience, who may not all be South Carolina experts. If you could tell us a little bit about the state and a little bit about the provision of behavioral health care in the state, we'd be so grateful.
Absolutely. So South Carolina's a state of 5.5 million people. Our mental health system is one of the few that's left that's actually a state-run system. And so we have our central office at the Department of Mental Health that actually runs 3 hospitals, which has a total of 400 beds, as well as 16 mental health centers that are spread throughout the state of South Carolina. So that we also have mobile treatment, which actually covers all 46 counties of the state. In addition, South Carolina is a very interesting state in that it's mandated to care for veterans nursing homes, which is very unique compared to the rest of the United States. And these are not folks that are mentally ill, but because we had a lot of mentally ill folks in our state hospital system, we were given veterans nursing homes as one of the things that we cover. We also cover forensics as well as our sexually violent predator programs as well. We have about 4,300 employees, about 2,000 contracted providers in our system.
Wonderful. Before I let you off the hot seat, can you tell us about what's working well? It sounds like you have a lot of good things in place. What are the things that keep you up at night when you think of behavioral health services statewide?
The same thing as keeping everybody else up, staffing and budget. I started my job April of last year of 2020. And it's interesting being there because it's the beginning of COVID, really. And so the thing that we noticed is that we had to immediately close facilities. We had to open up quarantine facilities, which of course increased our spend. We had a number of folks that have died of COVID, out because of COVID. And so the cost of that, just from a people perspective, has been really, really difficult. The other thing, too, that we've noticed is with the Great Resignation, we've had lots of people that have decided to leave the workforce. And so we've had to figure out how do we reconfigure our systems to be able to really be able to manage that. A lot more work from home, a lot more telephonic work that we've ended up doing, as well as telehealth in general.
Thank you for that. So Allison, join in the conversation here and tell us, we're talking about 988. That's a key central theme of our summit. So it's 6 months away. So with Dr. Rogers painting that picture, and I know you're involved in your state's task force, can you just sort of talk us through what's happening in South Carolina vis-a-vis 988, and sort of what are the challenges and obstacles?
So we, as a state, came together. We got a vibrant planning grant for 988 planning and convened a great group of stakeholders and started to kind of look at what can we do in South Carolina that meets the needs of our communities, but that also obviously can rise to the occasion of an unfunded mandate. It's going to roll out. We have mobile crisis all over our state. Dr. Rogers mentioned that. We have 46 counties. We run about 40 teams at a time, 24/7, 365. So we have that piece of it covered, we feel like, in a fairly competent way, and sustainable way. And so as that group convened and we started to look at 988 and the planning of it, it really boiled down to money. What are we going to do about who do they call? Who does somebody call that's in crisis? We only have one lifeline in South Carolina right now. Their answer rate is about 70%. We obviously want to increase that and get those calls answered in state. So as a result of that planning and those conversations, we really started to look at could we ask for, through our state budget, a recurring budget request that would support an additional lifeline center, so that then we could get up to 2 lifelines in South Carolina to try to get that answer rate higher. We also looked at improving some of our rural responses. Right now, those teams on average respond in about 32 minutes across our state. If you've not been to South Carolina, it is really rural in some areas, and then it's no Philadelphia, but it's not as rural in other areas. But we wanted to kind of bring that response time, even tighten the limits on that a little bit. So we asked for several $1 million in our recurring budget request to fund additional teams. Where that team came together and kind of what we landed on as a real opportunity for improvement in South Carolina is where do people go? Currently, we have 2 crisis stabilization units. But we need more. We need a break in the system of heading straight to the hospital. Even though our mobile crisis teams do a really good job of, if someone does require an inpatient bed, getting them straight to a bed from the community and skipping the emergency room.
Mm-hmm. So it sounds like that planning grant has been super helpful so
It has
far
been very
in
helpful.
illuminating some gaps. But let me ask you something. You said you asked, I believe you said, for several $1 million.
We did. So $5 million.
So what did they say?
So they asked, well, we don't know yet because the legislature's still out.
Okay.
But we'll find out. We're looking to our partners in the community to really kind of carry the torch on that fee, or for lack of a better word, this way that South Carolinians will interpret it as a tax. We typically tend to be a tax-averse state, so that's a bit more of a challenge. So we figured that we would keep one foot on both slopes and kind of go like, okay, we're gonna head for this recurring ask on the state end, and then hopefully let partners and let our constituents really work on that fee on the tax bill or on the phone bill.
Right. So you're talking about the telecom fee. And so tell us a little bit more about how you're addressing this. So you're saying that there's some entity in South Carolina that's spinning the telecom fee as a tax?
Well, I think it's more the way that it's interpreted, maybe from the public. It's another fee, on your phone bill. 911 obviously is a fee on our bills. While we're not against that, we really felt like, especially given the way that that's going to have to push through the State House, that the budget would come in sooner so we could at least get one part and one piece of that rolling. And then as this kind of law and more of the legislative ends of that come into play, then hopefully down the road, we'll have 2 sources of funding. That's where I think foundations and where different funding opportunities really come into play for a state like ours, for any state really, is that what do you do between now and then, right? Like how do you, where is there opportunity to say, we're gonna help get you through this kind of uneasy time? Because 988 is coming, whether we're ready or not, right? It's coming.
Right. I really appreciate that, and I certainly, as the Sozosei Foundation, as a funder, appreciate you amplifying kind of this funding gap in the interim as state bodies are figuring this out. Before I move on to you, Major, I have one more question. I know this is a litigator and just coming out.
I'm ready.
Better than the stand-up comic. Allison, I guess I feel like I think it would be helpful to hear a little bit more about this tax telecom fee dynamic. When you all are working so hard in South Carolina to fund your behavioral health care services adequately and with 988, how are you unpacking that message, or have you thought about sort of key communications with 988 and this telecom tax battle that you can share with folks?
Well, I would say it's still packed, Melissa. I would say that there is not a real robust conversation right now around that piece of it, and a lot of that has to do with timing. I know South Carolina is not alone in that, right? That your state house comes in and out. You've got these gaps in funding. You've got opportunities for a budget request. If that request doesn't get met, I think it's raising it to that public level of how does this impact me? How does it impact you? Not just me as somebody who's involved in policy or the administration of public mental health services, but how does it impact our families, right? I want my children, I have 2 teenage boys, if they were to need something, I want, similar to the panel earlier, I want it to be as reliable and ready and efficient for them should they have a need as 911 is. And I think we're way off from that, and we need to prepare and get ready.
Yeah, I appreciate that sort of straight talk from you, Allison, and I want to bring you into the conversation now, Major. So You know, we've been having some really interesting conversations about the role of law enforcement in a mental health emergency. And I think, you know, I would like to acknowledge that we're at a moment culturally and socially in the United States where we're having, I think, some really important conversations about law enforcement and its role in communities and how should we respond when our neighbors and loved ones and family members and maybe even ourselves are in crisis. And so we're so honored and lucky to have you here to tell us from that sort of bird's eye view your thoughts on that question. But let's start first with level set for us like Dr. Rogers did. What's the state of decriminalization of mental illness in South Carolina?
Sure. So as far as the Richland County Sheriff's Department, we are the largest agency, law enforcement agency in the state of South Carolina. We serve both rural communities and the metropolitan area as the capital city is part of, in our jurisdiction. And as such, we're about 900 officers strong. So we just took a step back and looked at last year in 2020, we responded to over 2,700 calls that were non-criminal. Mm-hmm. And that became a realization when we started talking about how do we address that, right? Because when people call 911, they're expecting a response. They're
Sure.
expecting somebody to come. And so it really put it on us to figure out, okay, so how do we serve them when they're not criminals? And it really opened the door for us to have those conversations about initiating a crisis intervention team, embedding clinicians in our victim services to do the long-term care, talking about embedding clinicians in our 911 center so that, we've been talking about 988, but the reality is 988, nobody knows about it. Mm-hmm. There is not a push of communication to educate the community about 988 and this service that's going to be available. 911, you teach your children from the time they're little. If you need help, call 911. So that's all they know. That's all anybody knows. If somebody sees somebody running down the street naked, screaming, who are they calling? They're going to call 911. Those are calls that law enforcement knows they're probably not committing a crime. They're in some kind of crisis. Mm-hmm. And it's super important for us to partner with the Department of Mental Health, and these individuals to respond to that together, in a collaborative form and not necessarily against each other. It shouldn't be their response or our response. It should be a collaborative response. And I think that is the position that Sheriff Lott has taken as far as our agency is concerned to decriminalize mental illness.
Mm-hmm. Can you sort of talk to us a little bit about that partnership? I think that, sometimes we talk about systems as if they're sort of happening out here, but of course we know they're made up of people. And I know that Sheriff Lott took a very particular and specific leadership role as the sheriff of the county to build that partnership. Can you talk to us about sort of how that started and what went well? And, I'll welcome you, Dr. Rogers and Allison, into the conversation here too. How did you all come together?
So it was a long conversation, so it doesn't happen overnight. And Allison could probably tell you a little bit more, but it was, a year's worth of conversations of back and forth about, what this looks like and how we can work together. And you probably know more because you were on the front end of those conversations.
Yeah. I think it started with Sheriff Lott being very interested in kind of rising to the occasion, especially following the civil unrest that we had here in the last year in our country, right? And how do we had a specific instance in Richland County that was highly publicized, the media, it involved a mental health patient or a mental person with mental illness. And how could we take that out of being primarily a law enforcement response and make it a collaborative response? And I remember talking to Dr. Rogers and talking to my deputy director and being like, all right, here's what we're going to do. We're going to take a full-time master's level clinician. We're going to put them in really plain clothes. Like, they're not going to be dressed up. We're going to take a plainclothes deputy and we're going to put them in an unmarked car and they're hitting the street. And that's what they're going to do. And they're going to respond to 911 calls that come in to 1068. So that's the law enforcement code for that. And so, we started with one team. It was really interesting. I participated along with my staff in the trainings. just on how to make sure that we understand that law enforcement is there to essentially keep it safe for us, but that once we're on scene and it's safe, then the clinicians take the lead, which is what we want to see. I'll tell you from what you hear in the conversations earlier, I worked mobile crisis on the streets for many, many years. I started on Lifeline when I was 18 years old as a volunteer. And it is so important that we not eliminate law enforcement from these responses, because sometimes you don't know if it's a behavior or if it's a drug, related or intoxication related call. It could be domestic violence, and it could come into you as a mental health call, and it turns out that it's not. So having them there and present is important, but what's even more important is that they're willing and able to step aside and say, we know who handles this best, and that's the mental health clinician. And that's what we do in Richland County. Those clinicians get on scene, they lead it, they work with the families, law enforcement's there to support, and we can kind of say, hey, make this phone call for me, will you help me, talk to mom, can you see if dad can give us any more information? So it really becomes a very approachable type situation. They're not that Major Yturria doesn't look great today, but they're not dressed like this. When they go out, they look like the rest of us in plain clothes. So that's kind of how it started. And then from there, we went to embedded clinicians, where we actually have embedded clinicians in the agency. And then now on to the 911 clinician that will actually serve as a mental health telecommunications operator
at our 911 center. So
right. So I appreciate that. And I think, one of the things we'll all be doing tomorrow with the Guild of Future Architects is sort of imagining the future. And it sounds as if, things are going well. So, that makes me want to pick at, well, what happens when it doesn't? And have there been incidents in South Carolina where you look at this model that sounds like it's really working in a really good partnership, where it hasn't gone as you expected, and can you imagine a future where it's just, and that's in heavy quotes, behavioral health care and law enforcement isn't part of the equation? So what hasn't gone well, and can you imagine a future where law enforcement has no role in behavioral health care emergencies?
Do you want to address the...
I'll take it. So I think that the question for me is it an either or? Because in my mind, where we are, I think, as a country, especially when it relates to 988 versus 911, is I'm always concerned about the safety of our employees. And so how can I send a master's level clinician into a situation that I'm totally unaware of what they're walking into? Mm-hmm. And so for me, it's incredibly important to have at least the involvement of law enforcement, whether they're immediately on the scene, whether they're clearing the scene, whether they need to be intimately involved to make sure that it's safe. Because I think the danger on the other side is if we ever have a mental health clinician that walks into a situation and is seriously harmed or killed. I think that for the department, that would be a much greater risk than having law enforcement involved. And I think that our partnership with law enforcement has been really good, because one of the things that you begin to see are officers end up really being able to incorporate the thinking of what to do with patients with behavioral health issues. Because the more that you're embedded with them, the more that you can influence the thinking of the officers that you're working with. And so if you're looking at an officer that's got somebody riding with them, every day, eventually that officer is going to be able to probably deal with 50 or 60% of the stuff that's kind of sitting in front of them without the clinician being involved. And so our hope is that we'll be able to change the thinking of law enforcement and how they approach by really being able to have some osmosis and facilitated diffusion across the two areas.
Yeah, and I'm just going to echo what he said. I really don't see where you can have a mental health person respond without law enforcement. When you're talking about placing people in situations, in homes where you don't know what you're getting into and you've not been trained about how to handle that situation. And so it was really important for us when we started this crisis intervention team about having a clinician and a deputy riding in a vehicle responding to 911 calls together on the front end to make sure that all of their clinicians were trained on law enforcement. Just the short of it about this is what our role is, this is what we're going to do when the call initially comes out. We'll make sure that the location is safe. If we tell you to do this, this is what we need you to do, because we have assessed something, in that situation that is not safe yet. And they have to also understand, what we expect, because if the situation goes worse, we need them to then get on the radio, because they're essentially serving as a backup to that officer as well. If additional resources are needed, they need to be able to call for those additional resources.
Yeah.
So I think it's important to have both.
I really appreciate all these perspectives, and I know everyone at home and here in Philly do as well. I feel curious about how you all are evaluating and measuring the impact of this work, and sort of what's right. If you think about behavioral health care and law enforcement, oftentimes there's different goals about, even an individual job evaluation and performance review. So how are you all, when you imagine the full state, using your data to look at this partnership and to say, is this really working? And what does it mean that it works? So that's open to anyone who
So I'll share a story real quick, and then I'm going to turn it over to Dr. Rogers for the serious data piece. But I did a presentation with Maria here a week ago and the sheriff, and I asked one of the CIT teams, I was like, can you give me a story? Like, I want a narrative, like some sentences that are not necessarily numbers based, that's like real life that a 20-year-old kid who's thinking about going into this profession could get. And so the example that I got was that a mental health patient that was involved in our system who had kind of fallen out of care. This person had not been in for their long-acting injectable in several months. I mean, they were not in a good place. And part of this person's mental illness is frequent visits to the emergency room. And by that, I mean daily, if not twice daily, visits to the emergency room in town. So that involves an ambulance ride, typically at least once a day. It involves law enforcement or some other entity us trying to get this person back to where they live. So anyway, we get it. We match it up with the data from 911 calls coming from this person. And the CIT team goes out, not knowing. And I actually was on the original call just to observe, to kind of see how they were going to do it. Go out. It did not. It was not what I would call smooth. It was met with some resistance from this person, and so they went out the next day. Well, so that was in June. So June and July, every single day of the month, at least one, if not two, emergency room visits. So the month of August, we get the person back in with the CIT team, transporting. I mean, getting this person back into the mental health center, getting that LAI administered, seeing a psychiatrist, catching up with nurse and a case manager. And in the month of September, that patient only went to the emergency room 9 times. So to me, that's where, I mean, that's where it matters. That's where you see that it matters, because this is somebody that, if you want to talk about the impact of diversion from emergency rooms specifically, or the diversion from jails, because that's more than likely where the person would have ended up because of some of the aggressive behaviors, that's where you see that it really matters. And that's not data the way that we're used to talking about it, but that's the data that we have right now, and that's just one of many stories that I think the numbers will catch up with, And I think Dr. Rogers probably can talk about our use of data.
Yeah, and so I think from a data standpoint, so our partnerships, we have a partnership with the University of South Carolina, both with the School of Psychology and the Department of Psychiatry. And so a lot of our data crunching really is a shared work between the two of us, the three of us really. And when it comes to that data, I think part of where we're struggling is we're really on the front end of building this thing, of where we're going. Right now we're in Richland County. We have been embedded some in Charleston County. So in our larger counties, what we find is that we are actually doing really well. What becomes less clear is in a very rural state. What happens when you get to a really small town that has a sheriff's department or a police department with 10 officers? Clearly, that's going to become a lot more difficult. And so part of what we're trying to look at is, as we're building this thing, how can we not just look at data for the larger cities, but how do we think about data for small towns? The second part of what you mentioned was the difference in thinking between law enforcement and mental health, and how do you measure those differences? I think the one thing that we both agree on is kind of the lack of negative incidents. And so that's really a big thing for us. And so far, that's been something that we're really proud that we've actually done relatively well. But then you begin to look at at things like the number of people that are actually showing up in our emergency departments, the number of ambulances that are having to go out for incidents as well. But then you can also look at the cost data. And so what you begin to see with the cost data is it's really unclear right now because we're having to ramp up clinicians, which are a cost. And so is that really a true offset in emergency room expenses or not? And I think we're at the point now where the data is so early in the process that we really don't know from a cost standpoint what's happening. We think that the programs are great. We think they're going to save lives. We think that the model is really a good model. But in terms of the data being able to prove it yet, it's going to be a little while.
So you're in that great place, Dr. Rogers. When we were ending the day yesterday, we heard from Sarah Stein-Greenberg from the D School at Stanford and talking about her book, Creative Acts for Curious People, and the importance of ambiguity and to sort of really live in this space of not knowing all the answers. And so I really appreciate you calling out that there's a lot of learning happening across the state and this data. Sometimes in states, data is siloed, and I'm going to make a guess that for many folks with us today, that they're in states or counties where law enforcement doesn't share with behavioral health care doesn't share back to law enforcement. You talked about your behavioral health care system being statewide, and I'm going to guess that that gives you some wonderful lack of silos, if you will. But how are y'all sharing data between law enforcement and behavioral health care, or is that also kind of a new space?
It is, and I mean, we actually created a database that is specific for all of our response from the dual response from the clinician and the deputy, the embedded clinician, in our follow-up, and it's going to be the embedded clinician on 911. We created this database where we're actually collecting all this data for future use to show, because you talked about it looks different. So for law enforcement, a win for us is not having to take someone to jail that doesn't belong there. A win for us is not having to have a deputy sit in an emergency room for 4 and 5 hours when he needs to be responding to, real crimes that are happening. Those are wins for us. And if we can get the clinicians to do the assessment on site, and, get the paperwork that's needed and transport that person to an inpatient or, whatever treatment is needed, and it removes the, law enforcement to do law enforcement duties, those are wins for us. That's how we're measuring wins.
Sure. That's marvelous, and thank you. I want to ask you something, Dr. Rogers, back to you, because you brought up the urban-rural difference. And I think that oftentimes, when we were thinking of these state snapshots with Ohio, and Director Chris brought up Appalachia versus their urban centers and rural and the mountainous regions. How are you all working to address the needs in rural communities? And when you think about them, what's sort of your wish list? If you could make a quick wish list for us, what would be on it?
Yeah, the difference between rural communities and our urban communities are so incredibly different. And part of it is, another conversation that we really haven't talked a lot about so far, and that is race. So if you look at South Carolina, we have the 3rd largest African American population in the United States. If you look at where a lot of folks live, it's going to be in rural areas. And so what you start to see that's going to complicate a lot of our efforts is our rural counties higher disproportionate confinement. And so there's already some issues that we're having to work through in terms of who's actually arrested, perception of policing, and those kinds of things that don't exist as much in some of our more metropolitan areas. And so the complicating factor gets to the social determinants that are much greater in those areas because of lack of resources. So for example, I grew up in a town of about 8,000 people that we actually serve. It's our smallest mental health center in the state. In that particular area, it's largely manufacturing and farming. And so with manufacturing plants closing, the tax base has dropped substantially. So now the big issue is not just mental health, but also substance use issues, which have gone through the roof recently. And so it gets back to the idea of data sharing and how do you think about it. So if we're in a larger city, we can all sit in a room, and even though 42 CFR and HIPAA will probably keep us from actually sharing paper with people, we can have a conversation about individuals in our community that we're struggling with and have it at a high enough level that we are really not breaking confidences, but we're able to get the message across. When you get into more rural areas, that becomes much more difficult. And so one of the wish lists is how do we, to your point, think about data, share data, look at data that will allow us to make, decisions based upon information and not just anecdote. Because my concern is that's probably a little bit of where we're living right now, because we have a model in our heads, we have this shared model, but is our shared model the right model? And I honestly don't know. It's that ambiguity that we're talking about. Do we really need law enforcement as we're going into the community? It's an assumption that we're working from. We don't know whether that's really true or not. We haven't had a chance to test it yet. And so as we continue to go along, I think that we will continue to probably push to look at the model and continue to refine the model as we go along.
Really appreciate that, and I hope you'll share it with everyone as you're learning, because, as Sozosei, one of our core values is curiosity along with creativity, and I think that that's really the use of data, is to sort of be in a constant state of comfort with ambiguity, curiosity about what we're learning, and then a willingness to share out and to be in partnership as we're learning together. While we're talking about rural communities and 988, can we connect those two? When you think about the rollout of 988 across South Carolina, and maybe Allison, you could begin, because I think that you're sitting on that planning task force, right? How are you all thinking about, if at all, the differences in 988 implementation and operation in rural and urban communities?
So in terms of the response, essentially?
Any way you want to answer it.
So mobile crisis that I talked about earlier, that is funded in South Carolina, partially through DMH and partially through a partnership with HHS. They respond in all 46 counties, so we again have a pretty unique opportunity here. I think Dr. Rogers and I both highlighted kind of that South Carolina is in this special space of being the sole provider of mobile crisis services or certain services in South Carolina. Back to that funding request earlier, I think that's a big key to it, is that where we see gaps in time. I mean, 60 minutes is a long time to leave someone in crisis, right? I don't want anybody to be in crisis for 1 minute more than they have to be. So if I can trim down our 32-minute average response time right now to 18 minutes or to 20 minutes even, I mean, that to me is a massive win. It's a great opportunity to make sure that we're de-escalating sooner, we're minimizing the need for law enforcement to be involved at a higher level. And in rural communities is really where you see that opportunity. I also think education is a big thing. That the story I talked about earlier, in rural communities, a lot of times that outreach and education, it's harder. It requires more manpower to get that out there. We've got to make sure that rural areas have that information, that they know what to expect and what's coming. And even in urban areas as well, we have to make sure that when a clinician and a plainclothed officer in an unmarked car show up, that they're not completely taken aback by that. I mean, that's a new concept to them. It's like, okay, hold on. Now all of a sudden the mental health clinician is like at my door instead of, just at the community. So I really think, I think it's response time in rural areas. I think it's education, and it's making sure that those services are the same no matter where you're located, that you have the same opportunity for help.
And I think if we're being honest, 988 is going to be a hard sell in South Carolina. And I'm not sure how we will sell it. So we've had a number of conversations with our legislature, and they're very open to funding crisis centers. They see the importance of it. It's great. We have plans on the drawing board for 3 centers in 3 different parts of the state, and those will probably be funded by our legislature. The thing that they come up with 988 is, like Allison was saying earlier, it's an unfunded mandate. We don't want the federal government telling us what we have to do. Related to 988, why are we adding this extra thing here? Because 911 is working just fine. So we're not going to add anything to a bill because that's a tax, and we're not going to increase taxes. Medicaid expansion is something that you would not ever bring up in South Carolina because it's a conversation that just is not a public conversation because bad things will be said. And so you don't have that conversation. And so it puts us in this interesting position of what do you do if you actually believe 988 is a good thing relative to how do you actually convince the policymakers to be able to do something different. And that's one we still struggle with. And I'm not sure where we will ultimately end up with the 988 discussion.
I'm going to guess, Dr. Rogers, that could cause some anxiety across the state when this is going live and there may be federal communications in July that here's this new number. What keeps you all up at night? If South Carolina is not interested in a long investment, and now I know never to bring up Medicaid expansion. When I come to join you all for dinner in South Carolina, we'll talk
skip
about
that part.
politics
That's right.
instead. But in all seriousness, what do you think might be the worst outcome when 988 goes live nationally? And how are you preparing to address that with this honest analysis of the landscape there?
Well, I think for us, one of the things that we've got, and I see Dan sitting there, is NAMI. NAMI in South Carolina has been incredibly strong in pushing 988. And so my hope is that their advocacy work and the grassroots is what will actually begin to change the minds. Because ultimately, if you can get enough communities involved, then I think that you may end up getting enough groundswell to be able to move things forward. So I'm hopeful that we'll see some changes related to the advocacy from our grassroots organizations, and I think that will change things. The things that keep me up at night is where you started, the bad incident that happens that you don't foresee. And I think that mental health is always under a microscope. Law enforcement is always under a microscope. And so you're looking at a place where you've got two different agencies that are scrutinized all the time, that are working together to do something. And if things go wrong, we're going to both get blamed. And then that blame is going to then have the waves of damage that will happen outward from there. And so I think that there's a certain degree of risk involved with really pushing the envelope and trying to do some of the things that we're trying to do. But also I think there's a lot of reward in doing it.
Yeah, great. I want to be sure that we're leaving ample time for questions because I have found this to be very interesting and I'm guessing that others do as well. But I want to go back to the question of equity and race and 988 and its rollout. And maybe we could start with you, Allison, since again, I'm calling on you because I know you're sort of sitting in this statewide task force. How is the task force embracing conversations about equity and accessibility around 988 and these differences across the state?
Well, I think similar to what we've been talking about today is what resources are available in communities, what is the information going to be that we provide to a community, and how palatable is that for them, how accessible is that information. I mean, we can hand out flyers all day long, and if it's not meeting the reading level of a community, it's not reading the, or it's not addressing the access level. Cell phones, somebody mentioned that in the panel earlier, you know, handing out cell phones if they're not available and people don't know how to use them. You know, from, especially from a race perspective, we recently designed, this was the highlight of our last week, my last week was we pushed out billboards for mobile crisis, and we put 5 up in every county to start across the state, and so they'll just roll throughout the year. And we tried to be very, very intentional about who was on the billboards and what community did they speak to and how relevant was it to you and to you and to you and to me, right? That that we could reach everyone. So we are having those conversations, and they're important to continue for sure.
Anyone else want to jump in on that? No? All right. Then I'm going to just sneak in one other question that I realized I really wanted to ask you, Major, and that is about 911 and 988. From a law enforcement perspective, when you look at those two numbers and think about, you know, are they colliding? Are they interacting? How is law enforcement viewing that in South Carolina?
So I will tell you that, and we talked about how 988 is going to be a hard sell in South Carolina. There is no communication to law enforcement. There is no communication out to the state right now as far as 988 and, and what it does. And so you also asked, like, what keeps you up at night? It is somebody calling that number and nobody responding, right? The people in need not getting the response that they want because we're pushing out to contact 988 when there is nobody on the other side of that line, and so, how do we do that? But as far as the collaborate response, we're also concerned about safety. That is our primary concern is the safety of the people, that are needing services, the safety of the people that are responding to provide services. That's a huge, deal for us to make sure that, that people are safe and we're not exploiting people and putting them into positions where they can't properly address the situation, that is in front of them.
Sure. Sure.
Or that there is a gap. If they respond and then it turns ugly and now they're calling law enforcement, there's a gap in not having somebody already there, to help. So.
Thank you so much for that. Allison, Dr. Rogers, you want to add anything about 911-988 before we go out to the audience?
No.
All right. All right, I'm going to take the first question from a virtual participant. Thank goodness I'm wearing my glasses, who writes, this is a suggestion for, I suppose, the panel and maybe everyone else here. Stop using the phrase behavioral health issues and replace this stigmatizing word with mental health challenges. I think, that's very interesting, and I think the use of language has been a sort of theme that's come up both at this summit and at our summit last year. And one thing that came up yesterday that was amplified this morning when Mary asked for some reflections on yesterday was this question of crisis or emergency. And so I'd love to hear the input from this panel on what do y'all think of those words? Is it mental health crisis as you speak about it in South Carolina, or would you say mental health emergency? And does that even sit differently with you?
I want to answer that question, but I also want to answer that one too.
Anything you want.
So when I use behavioral health issues, I use it intentionally because one of the agreements that we have between us, the Department of Mental Health, and in South Carolina, the Department of Alcohol and Other Drug Abuse Services, is that rather than saying mental health and other substance abuse issues, we use behavioral health to actually define any place that someone can go for substance use or mental health issues. And so that's how we define behavioral health in our setting. And so when I use behavioral health issues, I'm actually using it intentionally to mean substance use or mental health issues versus just mental health.
Great, thank you.
Maybe the issue is with issue, right?
Hold on, we need to get you to a mic so that our friends at home or at work can hear you clearly. And here comes the mic now.
Oh, thanks. I'm sorry, I just blurted that out. Because I was contemplating with you, actually, thinking out loud. Maybe the problem is not with behavioral or mental health, but rather with issue versus challenge. Just a thought.
Okay.
Thank you for sharing that reflection. I think that, one of the things that's so interesting, again, about South Carolina is this issue of the partnership and learning together. And I guess I would be curious, as you think about language use or these billboards that you were talking about, Allison, how do you all sort of share decision-making around communications, and what do you need to make your communications even better than they are?
I'll answer that. I think that goes back to data, honestly.
Yeah.
And I think opportunities for us to be able to see where people along this kind of continuum of care, of crisis or emergency care, whatever word we're choosing to use here, right? Where are they accessing services? Where are their challenges in accessing services? How do those services across systems communicate? You asked where we stay up at night. I'll tell you where I stay up at night is that mobile crisis has 1-833 number that people call, right? There's another number for Lifeline. that handles lifeline calls. And then you've got 911. 911 gets a little concerned about the liability of passing on a call that might come in as somebody with a suicidal ideation or behavior, right? Passing it on. I worry that there are just some gaps in communication at the service delivery level that kind of prevent us from talking maybe a little higher up about the system's approach to this. And without understanding where those gaps are, sometimes it can complicate our conversations at a higher level.
And the other thing I think that's really helpful is there's a reason why Allison's actually sitting in the middle between the two of us. And it's because her job really is to be the translator between law enforcement and mental health. Because she really is the person that is the linchpin that allows us to be able to communicate, problem solve, look at things in real time versus having to kind of run it through a big group. Because most things are usually very simple misunderstandings. And if you can have somebody with a 5-minute phone call that clears it all up, that's going to solve most issues. That's Allison's job. And she's usually the person that usually jumps in and has that conversation, and literally it gets rid of most problems before they actually ever show up.
That's a really helpful observation, and so we essentially need to duplicate Allison across the nation.
Available for duplication.
Right. But I do appreciate very much you bringing that to the surface of the conversation, because again, as Major, you and I were reflecting in an earlier question, sometimes we distance systems and forget that they're made up of people, and that there really is this important role, just like we're talking about breaking down data silos, there's an interpretive role across those silos that are so necessary. So thank you for that. I see we have a question from the live audience, and then I'll go back to virtual. Yes.
Hi, Tansy with 1M4. So I'm thankful, for my earrings, sorry guys. I'm thankful for the space to be able to stretch our thinking and our curiosity and creativity in this particular space. So I have about 7 thoughts, but I only have 2 that I'm going to 2 questions. So one, thank you to Allison for letting me know you have mobile crisis there in South Carolina, so I can add it to our list. That's one. And then I appreciate that you focus on having diverse people on the billboards when you were advertising it. My question is, did you also make sure that we're hiring diversely, so when people are calling in, they can hear a voice of someone who sounds like them from the community? And also for those who show up to be diverse responders. And so that's the first side, is how on the hiring side. And then secondly, I would ask us to really stretch our thinking in what is safety and who provides the safety. Because we're so used as a community to saying it always has to be law enforcement. Like, we have to have law enforcement there to keep their people safe or to keep the clinicians safe. But what about a safety steward who is not rooted in law enforcement? Because it's not like, we want to be safe too. Like, I understand you want to protect your clinicians and the law enforcement officers. You don't know what they're walking into, but the person who's calling you doesn't know who's going to show up either, or what that person's day has been. So make sure we just think on both sides of the aisle. So first, on the hiring side, hiring diverse. And then second, is there a way, if you want to keep people safe with a clinician or with a behavioral health specialist, can it be a safety steward or a security worker who is not rooted in policing?
Thank you.
I'll take the second part of that first. So why is our model the way that we have our model? Do I think a police officer needs to go to every call related to mental health? Absolutely not. I think if we had a way of really assessing what the call was on the front end, we could do that in a much better way. I think where we are in South Carolina, when someone calls into 911, there's not currently enough data around the entire state to really assess where we are. One of the things that we're looking at is, can we embed more clinicians into the 911 call centers so that that person is able to kind of do some triage and assessment there? If we're able to do that, I think that your plan makes a lot of sense, and that we really would begin to move in that direction. As it currently stands, I'm torn. I really am. I think that if you've got a plainclothes police officer who's there, it presents a degree of safety. And I'll tell you part of my thinking. So my background is I'm an ER psychiatrist. And so I'm living around danger all the time, which has probably colored my thinking. But most recently, we had 2 incidents, both less than a mile from my house. Both were folks with mental health issues, but folks that were also active shooters with weapons. And I started thinking, if one of my clinicians was the first responder on that scene, it would be a bad outcome. And that's not necessarily going to be clear from that initial call. South Carolina is a heavily armed state. I doubt there's more than probably 20% of the adult population that doesn't have a weapon of some kind. And so if you're in that kind of environment and there are that many weapons around, most people that you're going to encounter are going to have access to a weapon. And if you're having a crisis, are you more likely, not more than likely, to use that weapon? And I think that's one of the challenges as you get more rural, that you may end up with situations that may be more challenging than other places. But I certainly hear you, and I think that it's something we need to look at and think about.
Thank you, Dr. Rogers. I'm going to go virtual, and then I'll take an in-person question. This question says, the idea that law enforcement must be involved in all behavioral health care crisis calls has been proven not to be true in many areas of the country. 2/3 of all mobile crisis calls in eastern Iowa are handled by non-law enforcement currently. If the data shows, as with the Cahoots model in Eugene, Oregon, that behavioral health crisis calls can be handled by trained non-law enforcement, would you be open to integrating that model?
Now, I'd say we go out with law enforcement a lot. The other piece of this is our mobile crisis teams frequently work with people that are clients of the Department of Mental Health. And so in those particular cases, it's a client we know, we have a relationship with, we understand families, we have a chart available. In those kind of situations, much less likely to have law enforcement involved unless there's a reason to actually do it. So when we're talking about the calls, we're really talking about folks with whom we have no knowledge whatsoever of what's actually happening. But certainly it's a model we're willing to look at and continue to learn, because we're in the process of really trying to use the data that we're looking at national models and trying to figure out where do we go with it.
And I appreciate that focus on data. And just bringing us briefly back yesterday, a lot of what Dr. Neustadter from the University of Chicago was helping to illuminate was that there's not a lot of data with with regard to 911, and it's not routine across the nation. And so there's a lot of learning and opportunity there. Let me go to the live audience on the right.
Great, thank you so much. My name is Nastasia Walsh. I'm with the National Association of Counties, and really appreciate this conversation and coming up with so many ideas of how I can help our county elected officials as they're thinking about 988, most of whom have never even heard of 988. So I've been taking a lot of notes for our county officials. One of the things that I latched onto that you were talking about is that liability piece of if the 911 operator is taking a call, what kind of education, what kind of training, what kind of protocols, leadership can come from PSAP directors or sheriff's offices to help alleviate that, build trust that 988 is going to solve that problem, that they're not going to be held accountable, and then sort of like a interoperability question as well of, we've had folks asking, well, if they call 911 and they get transferred to 988, is 911 still listening to that phone call? Is my privacy going to be a concern because 911 is still listening to me? What if I say something about a crime I did and they're still listening? So I'm sort of curious. It's very sort of in the weeds, and maybe that's a whole nother panel for another day, but I'm just thinking about how we think about building up the trust, building up the relationships, building up the protocols so that people feel really comfortable that whether they're calling 911 or 988, they're getting what they need, and that folks are feeling comfortable with each other to be able to transfer back and forth if there is a need for that.
I don't mind speaking to that, and I'll bring it back down to a more human level. What I worry about with that is, if I'm in crisis and I call 988 or I call 911 and they say, nope, this needs to go to 988. I'm now being transferred to 988. I'm going to tell my story again. If 988 then decides, oh, hold on, you can go to a warm line, guess what? I'm now on call number 3. I'm telling my story again. If they say, oh, no, mobile crisis needs to be deployed, back to the mobile crisis line, telling my story again. Right? So at that point, I think because of the ambiguity in the response and because of this delayed response, there's inherently a liability there. We've kept someone in crisis for 3 phone calls now, telling their story 3 times, re-exposing them to their trauma 3 times. So, can we get past that? That's probably a question for an attorney, more so than me, but I also think that's where technology comes into play and what can we do to expedite and connect these people to the services they need quickly so that we know who needs to respond and when they need to respond and whether or not there needs to be an in-person response or whether or not it can be a phone conversation to provide support.
Allison, I appreciate that answer, and I want to amplify a paper that NRI just completed looking nationally at hotlines, warm lines, all of these different lines. On the Sozosei website, on the foundation website, we have a page called Resources, much of which have been shared by people who are participating in this summit. We have that paper there, and I think it's an interest. It unpacks some of this, but not all of it, but I just wanted to amplify that resource. And over to the left side of the audience.
Hi, my name is Dr. Talid El-Sabawi. I'm a PhD in public health. I specialize in mental health and addiction policy. And I just wanted to push back a little bit on the narrative that people with mental illness are violent, because it is a stigmatizing one and one that is not backed in evidence. So the panel has frequently mentioned data today. Not to discount any personal lived experience with violence and mental illness, because it is indeed valid. But Johns Hopkins University College of Public Health has an entire book about gun violence and the causes and a whole chapter on mental illness, disproving the idea that people with mental illness are more likely to engage in gun violence than other people. Additionally, if you just go into PubMed and type in demystifying this idea of mental illness and violence, you will find study after study after study that disprove this narrative. I understand it's a very salient political narrative, and you hear it frequently, and it is a real fear that maybe some clinicians feel, but researcher after researcher has disproved this narrative. So I just want to say, if we really are emphasizing the data, and that's what we care about, let's take a look at the data and have that inform our decision-making at the state level.
So let me respond to that one. So I hope that you have not taken away from what I've said that I believe that folks with mental illness are more violent than other people in the population. That is certainly not the message that I was trying to give. When we look at situations, especially the ones that I'm concerned about, it's not the person with mental illness that's the biggest risk. The biggest risk for me are the family members and the people around that cause problems. So for example, if I think about some of the more recent things that have happened, they've been related to things like domestic violence, situations where there was another family member in the home that actually became more aggressive and violent. And while I don't believe that violence is the issue, I think that as we're beginning new programs, there's the risk. And so I always think about, how do I look at risk management in my agency? I think we'll get to the point where through screening, through artificial intelligence, through lots of other screening mechanisms that we will have, that we'll be able to solve this issue probably in the next few years. Because there will be enough data to put in that says this is kind of where we are at this point, and be able to develop a risk profile, not for the individual, but for the place that that individual is sitting at that particular point in time. Because I can almost guarantee you that based on the world in which I live politically, if we had a negative outcome, the narrative is then going to be mental health is being reckless and putting their employees, who are all state employees, at risk. I've actually been called down to our state house for that a couple of times, just based on, are you putting state employees at risk by asking them to go into unsafe situations. And so we're leaning more toward the place of let's make sure that we don't have a negative outcome, look at where we will continue to develop over the course of the next year or two as we're able to put not just individuals, but begin to think about some of the intelligence that we can actually add into our computer systems to be able to go there. Because I absolutely agree with you. The last thing I want is a narrative that says that folks with mental health issues and challenges are more violent than other people in the population, because I don't think a diagnosis relates to someone's risk.
Thank you for that, Dr. Rogers. And we're running the clock on our time for our panel. And while I know that there are other questions, we're going to have to regrettably leave those for our social time. And I know you'll all be with us and we can enjoy more information from each of you. But as we close the panel, can I ask for any final reflections on what we've discussed, anything else that's come up or things that are coming up in the summit for each of you?
I think the biggest reflection I have is making sure that, we're all open to conversations and change. I mean, really that's what it comes down to. We live in a very fluid world, so we all have to be willing to have those, sit at the table, have the conversations, and be willing to change.
Right. Except for Medicaid in South
Except for
Carolina,
Medicaid,
which we'll never talk about.
We won't talk about that.
Allison, over to you.
I would say in closing, and we didn't get to this today, but that, of importance here as well is the importance of the mental health of law enforcement. And that so many times that's left out of the conversation because we just want to say, oh, they shouldn't have mental health issues. And the reality is they're human and they do. And bringing that into the conversation to say we need to also recognize and focus on and provide services to our law enforcement agencies.
Thank you for that, Dr. Rogers.
I'll end by saying I've enjoyed the conversation. I've loved to push back. It's like a lot of fun because it forces me to refine my own thinking and realize where my own blind spots and biases may be. So thank you to everyone who's actually pushed back and helped me rethink some things.
Thank you for that, Dr. Rogers, because that's something that we focus on a lot at Sozosei. There's a book by Adam Grant called Think Again that we focus on, which helps with questioning assumptions. And of course, as Sarah pointed out yesterday in her book, there's a whole exercise I really invite folks to bring back into their work about doing a rapid assessment of all of the assumptions you make about your decision making. It works both at home and as a single mother of 2 teenagers. I'll say it works at home, it works at work. With that, we're going to all go and enjoy wonderful lunch upstairs. We'll be coming back here. I'm sorry I've been separated from my timepiece. So if we could come back a little early at 12:45, just that will help us to pick up the pace. And don't forget we have the mural happening upstairs. We'll be leaving some time for that. So don't forget to energize the creative space. Thank you again, wonderful panelists. It's been an honor.
Thank you.
Thank you so much.